afternoon. First of all, I would like to thank the organizers, Jonathan, Magda, Dragana, Vilko, and the whole team for organizing this important meeting, and to you, Slava, for chairing this session. Apologies for not being able to join you in person this time. Lots of things are going on in Geneva at the moment. In my presentation, I will be addressing the question how we can progress with PrEP, sharing some thoughts and ideas which we can hopefully discuss later in this session. In order to understand in which direction we can or we should be moving with PrEP, I think it is essential to clearly see where we are with PrEP now. There have been definitely some positive developments in PrEP. Since 2016, PrEP is part of the Global Health Sector Strategy on HIV and UNAIDS Global AIDS Strategy, and those strategies have been helping and leading countries to adopt and implement PrEP programs and probably smaller projects as well where possible. We have WHO guidelines on PrEP recommending oral options, but also the upcoming long-acting injectables, which are innovations. And we have global targets, 21.9 million people accessing or using PrEP by 2025. We have WHO UNAIDS reports for 2023 and 2024 showing that 3.5 million people, which is less than 20% of the UNAIDS target, have been receiving PrEP at least once. And the new HIV infection rate is 1.3 million people globally. We do not have to go through this slide in every detail. However, I thought for many of you working on access to PrEP, it might be important to understand that both oral tenofovir-based PrEP options and long-acting injectables for PrEP are patented but also licensed, which means that generics are available or will be available as soon as they are manufactured, pre-qualified by WHO or approved by other stringent regulatory authority, and registered in countries where needed. For example, all tenofovir-based oral options have been available through MPP and Gilead license and supplied to a large number of low and middle income countries. Cabotegravir through MPP and ViiV license, and lenacapavir through Gilead bilateral licenses. This table can give you an idea of uptake of PrEP in WHO Europe region from 2012 until 2019. You can see that tenofovir-based oral PrEP have been supplied to 11 countries by MPP licensees, generic companies that Medicines Patent Pool have been working with, thanks to the license between Gilead and MPP. All in all, 1 million packs have been supplied until 2019. The biggest supplies, as you can see, were to Kazakhstan, Ukraine, Georgia, Armenia, and I think Uzbekistan. It must be noted that uptake did not stop after 2019. However, MPP licensees did not collect this data. As patent for tenofovir expired, consequently, any generic companies, not only MPP licensees, can now supply to countries where patent expired, which have been happening. So let us have a closer look at what is going on with PrEP in the region. According to ECDC reports in 2024, 38 countries reported having PrEP in some form. Of those, 21 are part of European Union or European Economic Area countries, which leaves us about 13 countries outside of the EU. Number of people who have received PrEP at least once in the WHO Europe region is almost 300,000 in 34 countries, including 21 countries in EU-EEA area. According to the Alliance for Public Health, by the way, thank you, Tanya, very much for providing this data, 10 countries in Eastern Europe and Central Asia are implementing PrEP in some form, with the biggest programs in Ukraine and Kazakhstan. Only in Kyrgyzstan and Moldova there are state-funded programs so far. Alliance for Public Health have been doing a great job in terms of PrEP, and not only in Ukraine, despite very challenging times, but also beyond Ukraine in other countries as part of the SOS project. I would like to thank you for that, and I'd like to say that it gives us all a lot of hope. Next question that I would like us to consider is why we have progressed well in treatment but less in PrEP. Well, perhaps we can better understand it if we could have a look at how the situation in HIV treatment has evolved over the last decade. As you know, dolutegravir-based products have been WHO preferred and WHO recommended first-line treatment regimens since 2018 and remain such until now. In 2014, ViiV and MPP signed the license. 10 years later, already 1 billion people were on TLD. As of September 2025, 1.6 billion packs of dolutegravir products have been supplied to 129 countries. As you can see from the timeline, it didn't happen overnight. I thought you might find this table interesting. This is just to give you an idea of uptake of dolutegravir products in WHO Europe region. 13 million packs have been supplied to 13 countries of the region by generic companies and MPP licensees. And once again, 13 million packs of treatments as compared with 1 million packs of PrEP. Progress in HIV treatment, and I would say success in HIV treatment, and in particular success in the dolutegravir story, is a result of the collective effort. The early license between ViV Healthcare and MPP is an important first step enabling access for most of low and middle income countries. However, it is the beginning of the story. Thanks to the license, generic manufacturers started manufacturing dolutegravir and dolutegravir-based products. UNITAID and other donors funded clinical trials to generate critical evidence for dolutegravir and TLD use. That, in its turn, enabled WHO to prepare and publish guidance on transition to dolutegravir products for countries, and then regulatory approvals from US FDA, WHO pre-qualification national were happening. UNITAID, as you know, played a key role in market shaping interventions and introducing the products in countries. PEPFAR and Global Fund played a crucial role in procurements. Governments committed to national HIV programs implementation and transition to dolutegravir programs as products as recommended by WHO. And of course, civil society and communities played a crucial role in advocating for equitable access, shaping policies in countries, ensuring that dolutegravir reached those in need. And many more partners contributed to this success. And this is the next question for us all to consider. Can lessons learned from treatment help us to progress with PrEP? Global stakeholders are increasingly drawing comparisons between HIV treatment and PrEP, trying to understand what next to be done in PrEP. And I suggest we do this exercise as well. Let us have a look into the factors contributing to the progress in HIV and compare those with PrEP. First, global political consensus. In relation to HIV treatment, I think we can confidently say it is strong. There is no question or doubt among stakeholders whether HIV programs should be implemented or not. The consensus in PrEP is less consistent, I would say. It could be explained partially by the fact that PrEP is a relatively new intervention, less than 10 years as compared with treatment. Regarding WHO and UNAID support, I think we can say with some degree of confidence that countries have strong guidance and support from WHO and UNAID and other agencies for both treatment and prevention. If we compare availability of treatment and PrEP regimens, here is what we have. In treatment, we have widely available generics for the first-line treatment. Please note that all first-line recommended treatments are licensed through Medicines Patent Pool. In PrEP, all oral options are licensed by Medicines Patent Pool and Gilead and available as generics as well. The long-acting versions of PrEP are also licensed and should be available as soon as they enter markets. What about funding? For both treatment and PrEP, UNITAID has been playing a huge role in initial product introduction, market shaping interventions, also CHI and other organizations. Global Fund and PEPFAR and other donors have been supporting LMICs to roll out prevention treatment programs. In treatment, many countries have transitioned or are in transition to more domestic funding. In PrEP, there has been still heavy reliance on donors. And in light of the funding cuts, there are concerns that PrEP would be even more deprioritized by countries, unfortunately. In terms of government commitment for HIV treatment, we can say we have strong government commitment in many LMICs, national HIV plans and programs, regularly updated guidelines, and where possible transition to domestic funding. So all of that is happening. In PrEP, we can see quite limited government commitment. Only 2 LMICs in Eastern Europe and Central Asia have state-funded PrEP programs. There is still lack of awareness on PrEP among all stakeholders, lots of stigma and discrimination, as you know, of populations in need of PrEP. And of course, as a result, there is no or lack of funding for PrEP. Implementation. HIV treatment is increasingly integrated into primary health care and community-led programs with decentralization and task shifting happening. partial or full state funding, transition to domestic funding happening as well. In PrEP, the situation, unfortunately, is more complex. Even if there is some implementation, it is uneven. There is no or lack of integration into health systems, complex service delivery, low coverage, mostly urban areas, no availability in rural settings. And finally, data and reporting systems. While in treatment we have robust reporting systems for almost 2 decades, in PrEP we have limited tracking of uptake and adherence and incomplete data. And finally, the last question is, what would it take us, the global health community, to succeed with PrEP? And whether the long-acting regimens would radically increase uptake? Well, I would say that we can and we will progress in PrEP, and we can radically increase PrEP uptake, provided we address the long-standing challenges which had existed long before we got to know about innovations, the long-acting options coming our way. Here are the challenges that we have identified when comparing treatment and PrEP. First, insufficient government commitment to PrEP. I would like to remind that the progress in HIV treatment happened once governments recognized it as a public health priority. Then, in PrEP, we have heavy reliance on donor-funded programs, and there is no sustainable domestic financing in most of low and middle-income countries. But in treatment, like lots of countries already started transition to domestic funding, as we know. In PrEP, we still have low awareness, and here the difference with treatment is that we are dealing with users who are healthy people, and in many cases governments are not willing to invest in healthy populations. Then we have weak demand creation. There is no life or death urgency as in treatment, driving the uptake. And we have to address service delivery barriers such as insufficient or poor integration of PrEP in HIV programs and healthcare systems, and insufficient support to communities and civil society groups and LMICs have to be also addressed, as communities and civil society are shaping policies in countries but also implementing PrEP programs. Thank you very much for your attention. Thanks again. I'm looking forward to hearing your thoughts and our discussion, and I do hope very much to see you all in person next time.